Yeah,
Please tell me.
yeah,
I
yeah.
was on a phone call with Dr. Kuti.
Okay. No. Dr. Naveen, no one has received this mail for login details. I
Sorry,
think they are
sir?
waiting. Dr. Naveen Thiagu, the speaker. Okay.
Yeah, but we have shared the login details to everyone, sir, on their mail ID.
Okay. So he is just waiting for that because he is not able to log in, it seems. Can you
I'm
just...
sending the link again to everyone, sir.
Okay, please send it again so that
Okay,
they will
okay,
log
sir.
in. Yeah. Thank you.
Most welcome.
Yeah. Hello. Hey, sir, I told her to share the link again. She told she will share it now. No. Okay. One second. I'll just...
It's very pleasure, and I am very happy to organize a webinar on the cat on the wall. The topic is on the cat on the wall, the dilemmas in orthopedics. I welcome all the speakers and the delegates. We'll have a nice time and academic event. We'll share our ideas, and we thank our Professor Rajagopal sir who has given this topic. He has nicely chosen. It is a very interesting topic. It's not full of theory, only case-based scenario. So I call upon the speakers. The first topic is by Dr. Chandrasekhar. Fracture neck of femur. We know it's a dilemma for always for orthopedic surgeon. And the speakers on this topic will be Dr. Chandrasekhar and Dr. Naveen Thiagu. One person is going to talk on, I'll do a cemented hemi, and one person is going to talk on THR, throttle hemi. Sir, shall we start, sir? Chandrasekhar, sir?
I think first Dr. Naveen Thiagu will start. No, is
okay. Okay, sir. Naveen Thiagu, are you ready?
Yeah, I'm ready, Vijayaraman. Am I audible?
Yeah, please, you can start, sir.
Am I audible?
Yeah, you're audible.
Audible.
Okay. I'll share the slide. So everyone is able to see the slide?
Yeah, we're able to see it.
Okay. So at the outset, good evening, everyone, and I thank the Dr. Vijayaraman for inviting me, and my wishes to President of Pondicherry Orthopaedic Association and Secretary General of Pondicherry Orthopaedic Association, as well as to President and Secretary of OASIS as well. So with that brief, I am going on to the first topic of this session. When the case given to me for the talk is like a 59-year-old female with 2 months old history of fracture neck of femur with comorbid conditions like diabetes, ischemic heart disease, and hypertension. So I have put the slides in such a way so that how this transition has happened from my postgraduate days. So it's nearly 1.5 decades now, and how my chiefs went through teaching. If I have a patient around 60 years of age with comorbid condition, whether to go for acetabular component as well, or only for the femoral component. And you all know there is hip fractures are very common, and it's estimated around in 2050 there will be more than 60 lakh hip fractures globally every year. It's there is a controversial. It's a very controversial topic, and it's so controversial. Why? And the reason why it is so controversial is, you can understand from this slide. If I put this slide 2 months back, and if I ask the the lifespan of these individuals, because one is 46 and another one is 56. And we are talking about a case of 59 years old. And so if you see, our predictions might not be very, very accurate when compared, when we assess, when it compares to age. So that's where exactly the controversy comes. Before me putting on my ideas about this age group of case and how I will go about it, let me take you through some of the literature evidences which are there available, which are very recent. And in 2019 JBJS Bone and Joint Journal, if you see in this study, they have compared around 67,000 cases of, it's from the Australian registry, 67,000 cases of fractured neck of femur and how they are managed. And in this chart, it's under the given age group around 60 years. If you see the 40%, around 40, less than 40% of cases are going for hemi, and the rest 60% goes for total hip. And if you see where that 50% line comes, it's around 70 years. So probably if we go back around 15 years, around a decade or so, and this might not be the same. And there is a shift in the gray scale, gray areas, which was 60 years of age. Now I think it has moved from 70 to 75 years of age. So another journal it's from the Journal of Arthroplasty from 2019. It's a meta-analysis as well as systemic review where several articles has been analyzed regarding this particular topic, where hemiarthroplasty and total hip arthroplasty in displaced fraction of neck of femur was done. So many of us usually have an idea whether to go for hip replacement or hemiarthroplasty, thinking that total hip replacement might have an additional parameter of infections when compared to hemiarthroplasty. But literature evidence from this meta-analysis shows clearly that there is no significant difference when we choose between total hip arthroplasty and hip arthroplasty and hemiarthroplasty. Sorry. And the next one, comparison between the bipolar hemiarthroplasty and total hip arthroplasty, coming from the same journal. If you see, it shows that bipolar hemiarthroplasty is shown to have a significant low risk of dislocation when compared to total hip arthroplasty. But when you come, there is no significant results included in 1 year mortality, in the post-operative infection, reoperation, and in the short duration of times. So what is that age group? Where is that gray scale? As I said in the first slide, when I started learning, it was 60 years. And if you look at the journals, it's all seventh decade or 8th decade now. So in this, they have put that cutoff as 80 years, and this mean age less than 80 years and more than 80 years they have compared. In this sub-analysis, if you see, it showed that hemiarthroplasty had a significant low risk of dislocation compared to total hip arthroplasty in less than 80 years of age groups. And there is no significant results in 30 days mortality rate, whether we choose hemi or total hip, or 1 year mortality, post-operative infection, and all those parameters. So what about when the mean age greater than 80 years? In this sub-analysis, if you see, and the hemiarthroplasty has significant risk of lower risk of dislocation again when compared to total hip arthroplasty, and no significant results in 30 days mortality or 1 year mortality and post-operative infection. Okay, now comes the exact area where that deviation happens. When are we going to choose, and what we have to have in our mind in the current scenario if we are choosing an hemiarthroplasty or total hip? It's all the number of years of survival of the implant as well as the survival of the patient. So when we follow up a patient more than 4 years, in this study it is 4 years. Usually going back, you should see the older literature, it all says 5 years. So in this study 4 years and more, if you see the fourth line, it says clearly there is significant lower mean Harris hip. HHS stands for Harris hip score when compared to total hip arthroplasty. So there is, when we want to choose between hemiarthroplasty or total hip arthroplasty, one of the most important aspects that we should have in our mind is the functional status and the quality of life of our patients. And especially in the longer duration, when the duration increases, this has to be considered, and it is better for total hip arthroplasty. And what is the reoperation rates? As we, in this same study, and they have pulled in a lot of data, and from the 10 studies, with the mean follow-up of 5.3 years, it showed a significant difference between the hemiarthroplasty and total hip arthroplasty groups. where the hemiarthroplasty groups went in for reoperation, and this goes in favor for total hip arthroplasty. So you all know it's a hemiarthroplasty is a less complex surgery and has been associated with reduced dislocation rates and reduced blood loss and lower initial costs. And it requires conversion to total hip arthroplasty due to complications such as acetabular erosion. In this case, going to this given case, it's a 59 years old, 2 months old presentation from the time of injury, and with the delay in presentation and today's scenario, less than 60 and 60, definitely total hip arthroplasty will be the first choice. And this conclusion from that meta-analysis of large group of pooled in data, it shows that THA is recommended management option for displaced fracture. DFNF stands for displaced fracture neck of femur in patients with predicted life expectancy of more than 4 years and in those under the age of 80. So as I said, this gray scale has moved from 60 to 80 in the literature. And the hemiarthroplasty is a reasonable intervention for elderly patients of more than 80 years and those with predicted life expectancy of less than 4 years. So in these patients, one is age. As we have discussed earlier, these patients tend to be live more than 4 years, and most probably this pre-injury ambulatory status at this 59 years should be reasonably good. We also need to know the cognitive status of the patient as well, and our resources that are available. Because in the Australian registry, if you see, most of the elective and total hip cases are being done in the weekdays, and whenever there is a fracture neck of femur in the weekends, if there is always most of the cases hemiarthroplasty has been preferred. So according to the resources also, there is some sort of change in the preference of total hip or hemiarthroplasty is there in literature as well. So what is that checklist we should have for a decision making? A quick checklist. One is age, and usually they say between the biological age and the physiological age, and it's a quick assessment that we have to do. And then the pre-injury ambulatory status, fracture neck of femur, it is little difficult, but we have to come to a conclusion quickly. And as I showed, 75 years of age, 70 to 75 years of age is my cutoff as of now. And that age group, according to the morbid status, according to the cognitive function, if they are neurologically impaired and there is a lot of memory loss or Parkinson's, something like that, that clearly differentiate between the total hip and hemiarthroplasty for my cases. And also, depending on the ASA score, the Anesthesia Society score, if the anesthetist says we have to have a surgical time, surgical time has to be very short, and also that also has to be considered when we are planning for hip surgery. And as you all know, and the medical comorbid conditions also stands for the long-term survival of the implant and survival of the patients, and to avoid a revision. So with all this, the final conclusion will be, if we are talking about, if you are thinking about the quality of life and better functional status of the patient, THR will be the most preferred choice. And in days to come, in probably in the next 1 decade or so, I have gone back to 1.5 decades and then come back today this time, and it has moved, probably it has moved from 60 to 70 to 75 now. And probably if in the literature, after 10 years, if you are going to see a literature, probably this gray scale might have moved to from 80 to 85 or 90. So with this, I would like to conclude my presentation, and over to the moderators. Thank you all. Dr. Vijayaraghavan.
Vijay?
Yeah, can you hear me?
Vijayaraghavan, yeah.
Yeah, it's a nice presentation. Thanks, Dr. Naveen Thiagu. We'll have the discussion at the end of this, the first session. Okay. I call upon the next speaker, Dr. Chandrasekhar, to deliver his speech.
Thank you very much, Vijayaraghavan. Good evening to one and all. And it was a nice presentation by Dr. Naveen Thiagu. I think to start with, the option of THA or hemiarthroplasty for the patients with neck of femur fracture is going to be a never-ending debate. As we all know, the concepts keep changing, and as we go on and as the life expectancy of each and every individual goes on, then obviously the concepts are going to change. So I'm going to strongly contradict the very strong statement given by Dr. Naveen Thiagu. Why? Because we know all the literatures available are basically from the Western population. Yeah, so then whatever applicable in Western countries may not apply to all the population all over the world, especially to an Indian country where our cultural habits are different. The incidence of osteoarthritis of hip and knee are compared to the Western countries are totally different. So in our population, people tend to sit cross-leg and squat, and wherein we see less number of osteoarthritis of the hip. And that is not applicable for the Western countries where the osteoarthritis of the hip may be quite predominant in their countries. That may be one of the reasons why the hemiarthroplasty patients may not fare well the long run. Okay, so with that a brief introduction, let me start what I'm going to talk on this topic of a patient with displaced fracture of neck of femur delayed for 2 months with comorbidities like systemic hypertension, diabetes, and ischemic heart disease. So what is my objective is to choose the best available treatment option for this given scenario based on the evidence in the form of randomized controlled trials, which is level 1 evidence, as well as the experience what we see over a period of years, the last 15 years, 1.5 decades, what we have come through all along with these type of patients in our scenario. This is more important. So I'm going to combine the level 1 to level 5 of evidence together and for a given situation. All right, so the why I have to combine this, because the literature which is available, the high quality literature, that is randomized controlled trials, all inclusive for the Western population, where the cultural habits are so different compared to our population. Okay, so the patient profile, if you look at, she is 59. So the life expectancy, average life expectancy from in our country is 65 to 68 years. A female patients, our females are not so active and so dependent on their activities compared to the Western population, where they go for golf, they go for all other extra activities for their leisures. And then the injuries delayed for 2 months, and comorbidity is quite a significant to take into account, where the management of the complication, the stormy postoperative course in setups such as in suburban levels are not to such an extent when we compare it to the Western standards. Of course, the tier 1 cities they do have, but not all the patients are ready to afford such treatment in tier 1 cities. Okay, so the given option for this particular patient is only hip arthroplasty. There's no question of, no thinking of internal fixation. So what type of hip arthroplasty is that debate? All right. So the hip arthroplasty, when chosen as a primary treatment, either in the form of total hip or any arthroplasty, the outcome varies, and the indication for such procedures varies nationally and internationally. So the predominant factors that influence the outcome is number one, the age, and then the surgical training and expertise by the treating surgeon, and of course the patient expectation. Of all these, the age and the patient's expectations are the most important factors to be taken into account, apart from the surgical training and expertise of the treating surgeon. So if you think the possibility of a total hip arthroplasty for a patient with a neck of femur fracture, then it is meant for highly active patient, where what does that mean? The pre-injury status of the patient, ambulant status of the patient is independent, is physiologically young patient, and his life expectancy is expected to be longer. And on an average, we cannot really predict very strongly, but on an average, we expect the patient's life expectancy to be longer with a highly active patient, and probably the established arthritis component, which is very, very important. I have to give importance for this particular factor, because such an arthritis is very, very less common in Indian population compared to the Western population. I'm talking about the primary osteoarthritis of the hip joint. So many of the time we don't see any evidence of established arthritis, or even the arthritic component following hemiarthroplasty is very, very rare in our population. So if we choose an option for hemiarthroplasty, then we tend to look for a less active patient and physiologically a bit older patient. Obviously, in our set of population, we don't expect obvious established arthritis, and then less or non-compliant patients. So why I have to take this compliance into account? It has significance. So later on my talk, I will explain why the compliance is also an important factor to be considered. So as Dr. Naveen pointed out, in all the literatures, the initial periods following total hip and hemiarthroplasty, if you do compare, the hemiarthroplasty group actually do well for quite some time. Then there is a steady fall in the functional outcome of hemiarthroplasty. It's true. Why? Because the patients tend to develop acetabular component problems like erosive arthritis of the hip or protrusion. So this literature is documented more in Western literature. We really do not have literature evidence in our country for our population, to what extent these hemiarthroplasty patients develop the erosive arthritis of the acetabulum, and that too as clinically symptomatic erosive arthritis of the acetabulum. Then the protrusion acetabulum. So the Western population, as I already informed, that those patients, they have a tendency to develop primary osteoarthritis of the. So in that situation, when the patients are subjected to a hemiarthroplasty, then the chances of development of acetabular component arthritis is quite high in such subset of population. We really do not know which patient underwent a hemiarthroplasty with or without an acetabular changes, and then how active those patients are. Whatever the studies say, they really don't take this into account. So whatever the given situation, if the hemiarthroplasty is chosen by the surgeon, then the patients are pulled in that group. So when we really think in terms of the revision surgery, which is a major setback for hemiarthroplasty in the Western literature, not in an Indian literature. So it is an erosive arthritis or the protrusion of the acetabulum. That is the only one factor which predominantly against the long-term outcomes of the hemiarthroplastic group. So in our subset of population where we sit cross-legged, where we squat, and we tend to see less chances of primary osteoarthritis of the hip, then does this really matters in our subset of population? That is the question we really need to ask ourselves before choosing the treatment option. So now I'm going to quote the available literature. This is the randomized controlled trial done in 10 countries over 80 centers with more than 1,500 number of patients, being published in the New England Journal of Medicine in the year 2019. So what if, when you look at this chart, the blue line indicates the hemiarthroplastic group and the red line indicates the total arthroplastic group. So to start with, on day one, this is the proportion of patients they require less number of secondary procedures following in hip surgery, secondary procedure for the hip. All right, so to start with, up to 4.5 years, that is almost about 500 to 550 days, the hemiarthroplasty fares well when compared to the total hip arthroplasty. Then what happens? After that, the total hip groups, they are in steady line. There is no further fall. Whereas in a hemiarthroplastic group, there is a fall and then there is a crossing over, and then they do much slower than the total hip arthroplastic group. Why is that? Because that is the time point wherein the acetabular component needs revision for these patients in hemiarthroplastic group. So that is a major setback for the hemiarthroplasty in the long run. So this available literature is for the Western population. Do we have such a data or statistical analysis for our patients? Obviously, we do not have. But personally, we have seen patients with hemiarthroplasty living without much pain, without much symptoms as far as the hip is concerned for quite long number of periods. So the major factors we need to take into account is the complication factors and its management. There are n number of complications with total hip as well as hemiarthroplasty. All that we want to do is that minimize these complications and thereby give the best possible treatment for the patient. So again, I'm going to quote the same journal, the New England, the article published in the New England Medical Journal. So this is a randomized controlled trial. As I told, it was done in 10 countries or 80 centers. So if you look at the hip dislocation chances in a total hip arthroplastic group, this is within 24 months of index surgery. So it's almost double the number of patients compared to your hemiarthroplastic group. And if you look at the other major complication in the same group is the implant exchange. There is a full implant exchange. So if you look at the total hip and hemiarthroplasty, it's almost 2.5 times higher than the total arthroplastic group. So obviously we know that the major complication in hemiarthroplasty is the revision surgery for the acetabular component. So when we really compare the complication rate, it's compared to the hemiarthroplasty and totally complicated. It is the revision for the acetabular component. That is the most important single most factor in hemiarthroplastic group, which makes it less efficient than the totally orthoplastic group. And if you look at the number of serious adverse events, though it is not statistically significant between the two groups, still the numbers are quite high. So you could see 300 major serious adverse events in this particular study in totally orthoplastic group, and it is comparatively less in hemiarthroplastic group. So though the statistical values of clinically insignificant for statistician, but still the number of patients, if you really think in terms of numbers, there is a good difference. Again, in terms of hip dislocation and instability, it's almost double the numbers in total hip arthroplastic group when you compare with the hemiarthroplastic group. So otherwise, if you look at all the complications, they are almost similar for both the groups. So if you look at the American Joint Replacement Registry, if you look at the revision within the 3 months of the index surgery, you know, the AOS guidelines recommendation, any patient who was previously ambulant independently presents with fracture of neck of femur after the age of 60 years, their protocol is to proceed with the total hip replacement. That is the AOS guidelines. So if you take that into account and then look at this slide, the number of index procedures done and the complications. The most common complication in this hip group is infection and inflammatory reaction, which accounts almost about 19% of the population who undergone for the hip replacement procedure. So next only to this particular complication is our dislocation of the prosthetic joint. So this happens within 3 months for revision. So the incidence is almost 18% for this hip arthroplastic group. And then comes the periprosthetic fracture. So these two are the major complications encountered in these patients. So as per the AOS guidelines, and then their indication for neck of femur fracture to undergo total hip arthroplasty is any patient who is ambulant prior to the trauma at the age of 60 or 65, then they are taken into total hip arthroplasty. So obviously we can understand the dislocation rates and the major serious adverse events and the periprosthetic fractures are more in case of the total hip arthroplastic group. Okay, so the picture presented to us today, our patient is a 59 years old patient. For our Indian standards, she may be considered as elderly patient, and the fracture is delayed for 2 months, and she is having significant comorbidity. So for me, this patient is a low profile patient with significant comorbidities, wherein my implant can withstand such a low profile patient definitely for about 10 years without significant acetabular component. I may not say that very confident, but I expect it to be, because in our personal experience, we have seen patients like that. So optimal procedure for this particular patient should carry a minimum risk. It should be of short duration with less invasiveness and less blood loss, with a quick recovery for early rehabilitation, and also should cover a cultural practice. So this is what I initially put up as a patient who's compliant. So our patient, they want to do whatever they want after some point of time of surgery. They really don't come for us. They don't say anything, then don't seek our advice at all. So they want to squat, they want to sit cross-legged, and many of the time they don't even come to follow up for our clinic. So then we have to chase those patients to go and see if he is a patient of your some project, etc., etc. So then you have to chase them back to home. So this is what they do whatever they want to do. So they are non-compliant patient. So when we really think in that way, then the hemiarthroplasty definitely is going to supersede the procedure compared with the total arthroplasty. So again, here I'm presenting an X-ray of an 82 years old female patient. She's presented for the hip pain on the left side. If you look at on the right side, there is an hemi-arthroplasty implant which was done at the age of 70 years. Now she's 82 and she has presented with intertrochanteric fracture on the left side. So when we really look at this patient and then decide what best to be done for this patient, should think all the possibilities of dislocation, the general complications, then the higher invasiveness of the procedure, and then the longer stay times. All these things needs to be taken into account. So then obviously my choice of treatment for this particular patient is to do an hemiarthroplasty on the trochanteric fracture with abductor reconstruction. So this is almost a 1 year follow-up of this particular patient. She is walking independently. So on one side, it is 12 years old hemiarthroplasty. There's no loosening or lysis on the stem. And then I don't see any arthritic changes on the acetabulum at all. She's doing quite well and she's absolutely asymptomatic for the right hip. So this is the level 5 experience. That is my own personal experience of our patients, how they do with some kind of procedures. So with the available Western literature, which may not be applicable for our patients in all situations. So compared to the total hip arthroplasty, hemiarthroplasty is a short duration procedure with less invasiveness, less blood loss, less dislocation, and less wound healing complication, and all the more it costs less than compared to your total hip arthroplasty. So as I told, the AOS and nice guidelines, they recommend the total hip arthroplasty for a patient with fractured neck of femur in elderly if they or pre-trauma status is ambulant. But with this study we published in the New England Journal of Medicine, the findings suggest that the advantages of total hip arthroplasty may not be compelling. Why? Because the limited advantage also carries higher risk of complications. And this is particularly important in regions of the world where the total hip arthroplasty is not easily accessible or is cost prohibitive. And also the incidence of secondary procedures after 2 years, they did not differ significantly between the total hip arthroplasty group and the hemiarthroplasty group. Obviously, the advantage is not so significant at the end of 2 years. So total hip arthroplasty, it was associated with modestly better function over 24 months, but with a slightly higher incidence of serious adverse events than hemiarthroplastic group. So the type of arthroplasty had no significant influence on the risk of unplanned secondary procedure at 24 months in this study. So in that study, they have concluded that the incidence of secondary procedure did not differ significantly between patients who were randomly assigned to undergo total hip arthroplasty and those who were assigned to undergo hemiarthroplasty. And total hip arthroplasty provided a clinically unimportant improvement over hemiarthroplasty in function and quality of life over 24 months. So this is the recently published journal from the New England Journal of Medicine. It's a randomized controlled study and the trial done in 10 countries, 80 centers participating. So with that background, what I would like to conclude is hemiarthroplasty is a less invasive procedure. It's a more affordable procedure. It's associated with less complication and it is more accessible. And thank you very much for the patient listening.
Thank you, sir. It was a very informative and elaborative talk on the hemiarthroplasty. Now the forum is open for discussion.
Is there any questions? The chat box? No.
Sir, can I ask one question, sir, regarding hemiarthroplasty?
Yeah, sure.
Sir, what is the longevity according to your you would have experience this many years? What is the longevity of the hemiarthroplasty in your scenario, in Indian scenario, in Pondicherry?
I think pretty much I've showed. That's why I put up that X-ray of 12 years hemiarthroplasty patient, cemented modular bipolar hemiarthroplasty, where the patient was brought in for fall when she was walking and sustained injury to the left hip. So what we generally tend to expect is a periprosthetic fracture on the operated side
Yes.
if it was an uncemented hemiarthroplasty. So this was done as a cemented hemiarthroplasty 12 years back. And then patient was asymptomatic for that hip, and when she fell down and then she sustained fracture on the other side. So if we choose appropriate patient, and then in this patient, probably the index surgery was planned in such a way that the implant will outlast the patient. But surprisingly, the patient outlasted the implant. It's not the implant as worn out, but implant is still there in good condition, functioning, and she is absolutely asymptomatic for the right side. It's 12 years now. So the patient now 13 years, because almost 1 year since I had operated on the other hip. So the patient is asymptomatic for the right side. Now she has come for the left side, and then she had undergone that procedure. So if we choose a patient who is less demanding patient, and in our population, the osteoarthritis of the hip, the acetabular component, the primary component of arthritis in acetabulum is very rare in Indian population. So if we choose a patient appropriately and then do the procedure, probably they last long, significantly they last long.
Sir, my question is another question. If the size of the head comes as 45, that is 45 and 47, it is in between 46, like that. He will prefer a 45 head or a 47 head.
Yeah, so whether you go one size up or down, it depends. So what happens if you put in a tight implant? If you choose a higher size, then the hip becomes quite tight. So in that case, then the chances of acetabular erosion and erosive arthritis, and then the related hip pain development chances are quite high. All right. So on the other hand, if you choose a smaller size, then you think the possibility of only the joint stability.
Yes, sir.
All right. So the choosing a smaller size implant, you're worried about the joint stability. Whereas choosing the larger size of the implant, you're worried about the acetabular erosion and arthritis. So you can always, if you're quite confident, like I do all my procedures in a lateral approach for the patient. So I really don't bother about the instability as long as my version, everything is all right. So then you can always go one size down. If you feel like you are going to end up in an instability, then probably you can choose an one size upper side rather than going for a smaller size, because stability is also an important factor, especially in the initial period. Later on, once the soft tissue heals and the 6 months down the line, it really doesn't make much difference.
Yes, sir. In this aspect, I want to share my experience.
Yeah.
We did one cemented hemiarthroplasty.
Okay.
One size bigger we put, as the smaller size was,
Okay, just show
we
your
felt
face.
as it was unstable, sir. So we went with one size bigger. Within 4 years, she came back to us with a protrusion, severe pain, arthritic pain. For that only, I asked sir, what is the longevity? It depends upon the implant size, the cemented implant size, and the activity of the patient. Even though she had comorbid of diabetes, IHT, everything, she was very active lady. She landed up with the protrusion. Then we later on went with the THR. With a big struggle, we have to remove the cement, and then we have to do a cemented hybrid. For that only I asked this question, sir.
Yeah, the
Dr.
problem of putting in a larger head is always you end up with the erosion of the acetabulum and then the protrusion, especially if the patient is subjected to osteoporosis.
Dr. Chandrasekhar, I do agree that hemiarthroplasty is a better option in especially in our state, our country. But do you see the osteoporosis in the bone to choose between hemiarthroplasty and THR, and also the acetabular depth and the shallowness of the acetabulum to decide on the total hip arthroplasty and hemiarthroplasty?
Yes, I do take into account all these factors. Here we have discussed for one particular given situation. So the discussion mainly on.
Was there an X-ray also?
So no.
No.
Okay, for the given situation, they have not given any X-ray. No, so
yeah, that's why I'm asking you.
Talk on that. So definitely we have to take into an account of the bone quality. So if the patient is quite fragile and then osteoporotic, obviously, and you put in a larger cup for a bipolar, then you do expect a protrusio or erosive arthritis in the acetabulum after some point of time, especially if the patient is quite active, physiologically active patients. A physiologically less active patient and less demanding patient, and then we can get away. Many a time we tend to get away in those patients. Where we really have trouble is only those patients who are quite active. And when we miss the osteoporotic component on the hip, and we put in a larger size of the head for want of the stability, then these two factors putting together in a highly active patient, physiologically young patient, then probably the chance of protrusio may be at a risk. So that we really have to take into account.
And the acetabular depth and the shallowness.
Usually, unless the head, so when we really assess these neck femur fractures, we always take the hip joint of both the sides. So we really will have a idea about the shape of the femoral head. Unless there is a dysplasia or the associated femoral head problems, then we don't expect the routine altered acetabulum, either it is a shallow or a vertical acetabulum. So most of the time we really don't. But in case if we tend to see an acetabular changes like they are shallow, then we really have to take that into account. It really makes a difference. Because a shallow acetabulum and then you put in a larger cup of head for want of stability, obviously we tend to expect protrusio and then erosive arthritis, and those patients tend to become more symptomatic for the hip pain. And then if the patient is also quite active again, so we are going to end up looking for a revision very early.
And even dislocations also in a acetabular dysplasia, right?
Sorry, I didn't get your question.
No, even dislocations are more in acetabular
Yes,
dysplasia.
exactly.
If you do
Dislocations are quite more.
okay.
Yes.
So I think for the information of the this one, I just add a center edge angle of less than 45 and acetabular depth of less than 19. I think it is better to go for a total hip arthroplasty. That's what he said. And moreover, Naveen, you were telling about weekdays doing total hip arthroplasty and weekends hemiarthroplasty. I think the more experienced surgeons doing the total hip arthroplasty are the more less experienced. So that might have biased your outlook on this paper, which is published also, right?
No, I just looked into the paper from that's from the Australian registry. What they have clearly said is the available resources, even in Australia, that's what the paper says. It's not what they expect from the weekdays and the weekends is little different. So probably going back retrospectively and seeing why many patients have been opted for hemiarthroplasty rather than DHR, and this point also has come into picture.
Yeah, that's why I'm telling you the problems, the complications of hemiarthroplasty is more when done by a less experienced surgeon. It is that's world known that about that fact also. So that might also have come into this. Conclusion.
And also another factor where the number of total hip arthroplasties are really gone so high starting from 2005 onwards. The study showed that the patient, when attended by a fellow trained in joint replacement surgery, has chosen a treatment option as total hip arthroplasty for a neck of femur, whereas a trauma surgeon has chosen a treatment option as a hemiarthroplasty. So after the 2000s, the number of surgeons trained in joint replacement is significantly higher. So the proportion of the total hip arthroplasties done by the guys, they are mainly joint replacement surgeons. They see those patients and then they go in for total hip arthroplasty rather than being handled by the trauma surgeon, where actually those patients have gone for hemiarthroplasty.
Exactly, sir. What Chandrasekhar said was correct, and that's one more factor that they said. Because in the weekends, the trauma surgery, it's a fracture case. It's not an elective procedure. The fracture case seen by trauma surgeons, and they usually go for hemiarthroplasty. And one more point is that the available resources also, the backup that they have during those times, the weekends also, that was not up to the mark of according to their standards. And so the elective people who regularly do hip replacement cases, and if that fracture neck of femur trauma case lands up to them with them, they usually opt for total hip arthroplasty more in numbers when compared to the trauma surgeon when they see those cases in the emergency department in the casualties. That's correct. Yes. No. Okay. Good, sir. Good discussion. Because actually Chandrasekhar has had a very difficult shot to take. So because it was a little easy for at that age to go ahead with total hip replacement, but he did very well, and I think even with, I would take a message like I would try an hemiarthroplasty at little earlier age groups.
Thank you.
Sir, one doubt, sir. Shall I ask to Chandrasekhar, sir?
Yeah, sure.
Sir, what is the status of cartilage in this particular scenario? I'm asking. 59, 2 months old neck of femur fracture, unloaded joint. What is the status of acetabular cartilage in a female patient when it's not unloaded?
Yeah, that's what I want to say. It's
Yeah.
not completely unloaded. What it means, even the patient is a bedridden, there's some joint force acting on it. So we really don't expect the cartilage to be worn out, especially in our scenario where the primary osteoarthritis of the hip is not so common. And that is not really applicable for Western country people, where we primarily expect the acetabular component and the arthritis on the hip for those patients. So in those situations, and then you leave the joint and then allow it, already there is an acetabular erosion or cartilage erosion, pre-trauma status, and then the trauma 2 months left over, then there could be a significant inflammation. And then probably the cartilage would have gone through even arthritis erosion, significant erosion. But that is not the case in our scenario, where we have operated for 6 months neck of femur, patients neglected, and then put them on skeletal traction and then do a hemiarthroplasty. And then we tend to see the acetabulum really what is the status on it. In our population, it really doesn't go for such an erosive arthritis unless there is a trauma to the head itself, not at the neck level also, head itself, wherein then you can expect some kind of secondary chondrolysis. So obviously it's going to be evident on the intraoperatively. It's very rare to really see such a situation in our.
It's really rare.
The significant reduction in the hip joint space on X-ray taken just before the surgery, you will have much better idea what is going on, especially on the weight bearing aspect. You tend to see an erosion in the bone itself if there is a cartilage denudation. So there are some telltale evidence that you can take into account. And also you need to be very careful. One of my cases where it was delayed for 2 months, and then we planned hemiarthroplasty, and then we opened up, it was full of pus. The patient was absolutely asymptomatic, full of pus. So what we have to do, we just excised, we did excision arthroplasty, then put in antibiotic. Luckily we had an antibiotic, then we put in antibiotic beads therein. So then we planned for a revision of the procedure later on, but the patient didn't come for follow-up at all. Sometimes you tend to have surprises like that, especially in our scenario. So you may be prepared for everything. So for a given situation we are talking, we discussed about, but it would be always, be on the safer side to keep even the hip arthroplasty component on the side, so that intraoperative surprises, the intraoperative surprises, you should not, it should not withhold your procedure, the ideal procedure for the patient, because the patient may not be fit for the next surgery. So on the single shot, you should be able to do the best for the patient. So if you come across an arthritis of the hip or the erosion or something else in the acetabulum, then if the patient requires a THA, then you should be prepared for that as well.
Yeah, that's what some people say. I don't know. I looked into some cartilage studies. So they say when the cartilage is unloaded for a while, then your nutrition. So the architect should be maintained for the cartilage to survey. In female patients, particularly.
Most of these literatures, they are Western literatures. We really don't have a standard
in our country.
In our population, there everything is delayed, and the some patients they do extraordinarily well. You really cannot match these two the Western
with the population.
We don't have a good literature on that. That's the problem.
Yeah. To add on one more thing, sir, what Vijay Raghavan sir asked. The other thing is, it's more than the head size. It's the offset. That's what I have come up with a paper. Soon I will publish it. It's the offset. I think everyone is taking granted if it's a hemiarthroplasty. Okay, everyone is not taking it serious as a hip replacement. I think hemiarthroplasty also should be taken seriously as a hip replacement. The offset should be restored. Here we are not worried about acetabular offset. We are restoring only the femoral offset. The femoral offset should be restored. The non-modular processes which are locally available, we are doing it for cost-effective procedure. These processes we put, the offset is really high. You tend to go up to the calcar level, you go to the lesser trochanter level to sink in the processes, and you put a larger offset, and the acetabular goes for erosion, and these patients come up with protrusio. Now we have got, at present, we have at least two patients in our ward with this kind of scenarios. So that should not be done. That should be taken into consideration, and a proper preoperative planning is very, very important in hemiarthroplasty also. It should not be taken granted, and it should not be a weekend procedure by a low grade surgeon. That's what.
Exactly.
Yeah,
So
that's great, Santosh.
bimodular
Yeah.
prosthesis,
Yeah. Yeah.
the stem size, different companies have different sizes.
Sizes.
Yeah, so you really have to look into that. That's why you need to develop limb length discrepancy, very tight mechanisms of the soft tissue, everything, which ultimately results in these problems because of improper offset. So choosing a proper bipolar processes, especially when it's not modular. That's very important.
That's very important.
And
Vijay, there is a question in the chat box.
So the question is, Chandrasekhar, it's for you. What is the longest follow-up and what are the numbers?
Yeah, for me, I showed one patient of 12 years. I have a really good number of patients, maybe around 50 plus patients with more than 8 years. All are cemented modular hemiarthroplasties.
The message should be like, as I said, there should be a balance, because over the years, as the evolution of the implant is also happening, as the longevity of life is increasing, there is a lot of evolution of the implants, especially total hip implants have evolved over years, and now their longevity is far, far better. So when you want to give a patient one surgery, and if you expect the patient is going to live longer, more than 4 years or 5 years, I feel a total hip will be the best option to give. It's a one surgery and with a long lasting implant. And this case, I'm not coming to this case only, but in the general scenario, I'm telling. And age as a criteria, definitely that 60 years has moved from 60 to 70 years now. So if any of the beginners or who are into arthroplasty or into replacements or wants to be in the replacement or hemi or total hip, whatever, you have to see only two things. One, how many years is the patient is going to live? That is difficult to predict. That's why I put that slide. One is 56 and 46
really
years.
Can't predict, and especially in our scenario where the demand for the patient really varies.
Yeah, that is one thing. And want to give one surgery, and that calculation has to happen within seconds in trauma. So how long the patient is going to live, how long my implant is going to last. These two calculations have to mentally, it has to happen. That's why I gave the checklist. So with that calculation, we have to go inside the theater, and we should be prepared for surprises. If you are planning for hemiarthroplasty, we should be acetabulum erosion can be there, as Dr. Santosh also pointed out, and we should be prepared for total hip arthroplasty. And years, as I said, 1 year, 30 days, 1.5 to 2 years, it's all same. Hemiarthroplasty and total hip, the functional status, Harris hip score, most of the studies have given same reports, but the deviation exactly happens 4 years. So if quality of life, after 4 years, if you want to give a better quality of life, total hip will be the best option.
But taking the dislocations, hemiarthroplasty is more forgiving than we'll have to say that, right?
No, it has to be balanced. We have to strike a balance. That's what it has to be individualized for the patient. That's why I said it has to be individualized for the patient according to the demands of the patient. So we cannot calculate it overweight, give a overweightage for a dislocation for a patient who is dislocation for an elderly patient or younger patient. It's a calculation that has to be made into a matrix where everything has to be put into place. So hip dislocation in total hip, it is there in the studies, but when we are choosing a surgery, of course we need to have a lot of, as an orthopedic surgeon, we know a lot of complications are always there in our armamentarium. We see day in and day out. But when we want to make a choice of one surgery, giving the best surgery for the patient so that it lasts long, I would say total hip will definitely have an outscoring over hemiarthroplasty, especially in this age group where 60 to 70. If you see 20 years back and now, definitely there will be a lot of general population attitude and their activities has increased quite a lot, and the lifespan has increased. So I'm not surprised, as I said, this 80 where I stored 80 cutoff mark might increase to 85 in another 10 years to come. So
yeah, sure, Naveen.
Yeah.
But dislocations are maybe less with expert hands, but hemiarthroplasty is always more forgiving, right?
Yeah, it is forgiving.
That's what I'm telling.
But sir, I've seen dislocations even with hemiarthroplasty.
Yeah, that's
I've
true.
seen if the trochanter and abductor mechanisms are not taken into consideration, definitely either it is THR or hemiarthroplasty, it's going to happen one day.
That's true. That's true. Faulty techniques,
The fundamental principles has to be there.
but it's more forgiving.
Yeah.
That's what I'm telling you. Well, you should be very expertized to have a good outcome in totally than in hemiarthroplasty. That's what I'm telling you.
Yes, sir. So if it is 80 years, 80 patient, there is no question about it. So we go from hemiarthroplasty. Having a scenario of around 80 years of age, probably because definitely now, if you see, sir, I was searching for, to be very frank with the panelists and the audience, I was searching for the age group of the population, the actors, and this thing, because I was seeing Amir Khan is around 56, and if I had to compare Amir Khan with an actress, I remember Juhi Chawla only. If Juhi Chawla comes for a hip fracture neck of femur with the fracture of neck of femur, I would definitely give a total hip rather than a hemiarthroplasty. I think most of the audience would agree with it. So lifespan is.
Let's pray that Juhi Chawla will not hear this conversation.
Okay, thank you. It was very nice discussion. Thank you also. Thank you, Chandrasekhar. And Vijayaraghavan, thank you. Santosh,
Yeah. We had a lot of information, sir. Thank you, sir. Thank you. So the next topic is a trauma topic. All are trauma only. This is a 24-year-old male. Can you hear me? Sir, can you hear me?
Yes,
sir.
we
Yes,
cannot
sir.
hear you.
Yeah, 24-year-old male with a short oblique fracture with a minimally displacement shaft of humerus, middle third distal third junction, without any comorbids and without radial nerve palsy. How will you approach? One is the non-operative treatment, another is the operative treatment. The Professor Gopi Shankar Balaji has come for non-operative treatment. I welcome Dr. Gopi Shankar Balaji to have his talk on non-operative treatment.
Thank you, Dr. Vijayaraghavan. Good evening, all. I thank the organizers for giving the opportunity to give a talk in this webinar. Are my slides visible?
Yes.
Yeah, so this is the scenario given. So we have a 24-year-old male with an isolated, closed, minimally displaced short oblique fracture of the middle third, lower third junction with no comorbidities, and radial nerve is intact. So I'm here to talk on non-operative treatment. So any patient comes, we usually do a clinical assessment. So this is a young patient with an isolated closed fracture. You can see the soft tissues are normal and patient is not too bulky and radial nerve is intact. If you see an X-ray, it's minimal displaced, alignment is fairly okay. And if you're planning for a conservative treatment, you can very well put a coaptation splint all along up to the axilla. So fracture is well below, so can be easily treated non-operatively. So just a basic introduction about the humerus fractures. Almost humerus fractures accounts for 3 to 5% of all fractures, 60% of which occurs in the middle shaft. Mostly they are females and left side is more involved compared to right side. And there is a ever-ending debate whether it needs operative management or non-operative management. Though Sarmiento has popularized functional brace and non-operative treatment, there is a recent increase in trend in operative management. Suppose the problem with a distal third, middle third junction is most of these fractures have usually a butterfly or it is a spiral fracture. So what happens is if you are planning for operative management, you have to expose the radial nerve, and radial nerve is at risk. Number two, this bone contour has to be addressed. So you won't be able to use a straight plate. You need a curved plate or you need an anatomical plate to address the issue. Second thing is when you go more distal, you might have to use unicortical screws, which also affects the stability. So in addition to this, you have to worry about infection and wait for the union. So we prefer non-operative management in these type of injuries. So what are the fractures which is amenable for non-operative treatment? Isolated, low energy, middle third or lower third fractures, closed injuries, and the patient should not be too bulky. If patient is too bulky, then it becomes difficult for them to manage conservatively. Second thing is, since the young patient, suppose instead of a male, it is a female patient, again, cosmesis also becomes an issue. So we prefer non-operative treatment. So what are the basic prerequisites for non-operative treatment? Number one, patient should be compliant. Patient should be able to sit upright because the reduction is by gravity aided. And surgeon should understand the deforming forces. And patient should be ready to come for regular follow-up. So how do we treat? We make the patient sit upright and give a gentle traction to counteract the deforming forces. So initially for 7 to 10 days, we usually give a coaptation splint for the swelling to subside. If you see these fractures, they are more prone for a varus. So you always, when you put a plaster, you should give a mold, valgus mold. So the ideal acceptable criteria is 20 degrees of anterior posterior angulation, 30 degrees of varus angulation, and 3 centimeters of shortening. So once the 7-10 days of post injury is over, what we do is we make 4 strips, 12, each of 12 layers, which is 5 centimeter to 7.5 centimeter broad, depending on the circumference of the arm. And we use the lateral strip, medial strip, anterior strip, posterior. The lateral strip starts just distal to the lateral epicondyle, goes proximal to the acromion. The medial strip starts just distal to the medial epicondyle up to the axillary folds. The anterior strip extends just 2 centimeter proximal to the anterior elbow crease up to the AC joint. The posterior strip from the just above the tip of olecranon up to the AC joint. All these 4 strips meet proximally at the AC joint. First, we usually put the medial and lateral strips and we try to mold it and correct the lateral and medial angulations. Then we place the anterior and posterior strips and tighten and prevent the anteroposterior angulations. And then we apply bandage over it. Most of our patients are not affordable, so we usually try a functional cast brace. If patients are affordable, you can use the regular commercial one. So we follow the patients regularly every week. Elbow ROM is started initially. We check the patients at 6 weeks, and then we check for mobility and do X-ray to look for any callus. At 6 weeks, when there is signs of healing, we usually start shoulder ROM and gradually wean it till 10 to 12 weeks. So having decided to do non-operative management, what are the dilemmas I have? Is this treatment better than surgery? Will the fracture unite with non-operative treatment? What are the complications I'm going to face? Till what time I should continue this non-operative treatment? And when should I convert it to operative in case if it fails? So first question, is non-operative management better than surgery? So there is a multi-center RCT done by Ramo et al. It is published last year. It shows that surgery compared to functional bracing did not account for improved functional extremity function at 12 months. This is a systematic review. It showed that majority of humerus fractures can be managed non-operatively. However, the non-union rate is slightly higher, 17.6 compared to operative treatment, which is 6.3%. But operative treatment has a iatrogenic nerve injury risk of 3.4% and infection rate of 3.7%. This is a Cochrane review, which shows there is no evidence available from RCTs till now whether surgical intervention is better or worse than non-operative intervention. So will my fracture unite with non-operative treatment? So let's go to Sarmiento et al. So in all his papers, starting from 1977, 99, 2000, he has shown very good results, treatment with functional brace. So he has showed in 2000 paper, he has showed union rate of 97.4% and average healing time of 11.5 weeks. And 81% of patients had an angulation less than 16 degrees. There are multiple papers showing union rates ranging from 80 to 97%, which is actually good when compared to this thing. So we did a study on non-operative treatment of closed humeral shaft fractures 2 years back. We had around 83 patients, out of which 61 had middle third fracture and 22 had distal third fractures. 57 of the patients had transverse fracture, 12 had oblique fractures, and 14 had spiral injuries. So among middle third fractures, 85% had union by 12 weeks. And among distal third, 81 had union at 12 weeks. Based on the fracture pattern, 92% of transverse fractures had union, and oblique fractures, 83% had union, and 50% of spiral fractures united. Just few examples. This is one of the case, 50-year-old female. This is a immediate X-ray after reduction at 6 months follow-up, and this is a 15-month follow-up. Patient had a good shoulder ROM at the end of 15 months. This is another case of 60-year-old lady who had a fracture shaft of humerus, which was treated conservatively. This is an image after 6 weeks, after 1.5 years. So, of course, we have to face few complications. So what are the complications we have faced? One main problem is patient compliance. Patient should be compliant. Otherwise, non-operative treatment is not going to favor you. So patient should be compliant, and sometimes he might feel the brace is too bulky and he might not have good sleep. He might have to have all these issues. So patient who is compliant is the first number one. Number two, he has to come for regular follow-up, because every week we need to tighten the bandage. Otherwise, once it becomes loose, the production goes off and it fails. The most common complication is non-union, followed by malunion and stiffness of shoulder and elbow. And sometimes you might have skin problems. So coming to non-union. Few studies have showed that proximal third spiral or oblique fractures are more prone for non-union compared to middle and distal third. Another study has shown that transverse fracture with distraction at the fracture site is more prone for non-union. Again, chronic alcoholics are more prone because they are less compliant and they don't use the brace as advised. So that might be the reason. And obesity is also more unfavorable for union. Smoking, few studies have showed smoking as a significant predictor of non-union. In our study, we had 13 non-unions, out of which 9 are chronic smokers. Coming to malunion, usually malunion less than 20 degrees in both the planes are well tolerated because the shoulder and elbow has a wide range of movement and they usually compensate. Cosmesis is usually not an issue with malunion of the humerus. This is another study which showed that residual angular deformity of around 18 degrees in sagittal plane and up to 27 degrees in the coronal plane did not affect the patient reported outcomes. This study showed that conservative management of humeral fractures yielded satisfactory shoulder and elbow functions. However, the shoulder ROM is restricted when the varus and antecoitum is more than 20 degrees. This is a study done by Papasoulis. He did a review of all the previous literatures and found that almost 79.3% of patients had full shoulder function and 85% had full elbow range of movement. The most common affected range of movement is external rotation, followed by abduction and forward flexion. So till what time you need to continue non-operative treatment and when will you convert this to operative? So there are few parameters. First is, as I said, at 6 weeks, you remove all the brace and check for fracture mobility. The fracture is mobile at 6 weeks, then the study says that there is high chance of non-union. There is another radiographic score which predicts humeral non-union. This is given by Oliver et al. So they give a radiological score. They look at the callus of all the 4 cortices of the humerus. 0 is given for no callus, 1 is given for callus but it is not bridging, number 2 is given for bridging callus. So total, the score is less than 8, it is predictive of non-union. A score more than 8, you can still continue non-operative treatment. Decker et al. Did a study to validate both these previous studies, and he found that if there is mobility at 6 weeks at the fracture site, that means the 6 times more likely to have non-union at the end of 6 months. And if the radiological union score is less than or equal to 7, then there is 14 times more likely to proceed to non-union at the end of 6 months. Another study showed that the fracture gap also equally plays a role. As we saw previously, transverse fracture with distraction, usually they go for non-union. Similarly, each millimeter gap, increase in the gap, results in 40% increase in risk of fracture mobility at 6 weeks. Also, increased risk of fracture mobility is there when patient is a chronic smoker. It nearly increases the chance of fracture mobility to 6 times. Of course, when conservative treatment fails, you have to go for operative treatment. The other indications are open fracture, severe soft tissue injuries, segmental fracture, when there is a vascular compromise, or when there is a pathological fracture, which the next speaker is going to talk about in detail. So to conclude, non-operative treatment is still a better option. Of course, it is cost effective and they have excellent functional outcome with very low complications. However, it all depends on patient factors and injury pattern. Always discuss both the pros and cons with the patients and then decide on treatment. Thank you.
Thank you, Professor Gopishakar Balaji. It was a nice presentation. We'll have the discussion at the end of the session. I call upon Dr. Santosh Kumar to have a talk on open retraction impedance fixation of distal third middle third humerus fracture. Please go ahead.
Good evening. Thank you, OASIS team, President, Vice President, and POA for giving me this opportunity. So today my talk is on distal shaft of humerus, why I do surgery. Okay, let's go to the debate. So the given case scenario is 24 years old male. It's a short oblique fracture, distal third shaft with no comorbidities and no distal neurovascular deficit. So I'll start with the anatomy, why I want to do surgery for this kind of patients. So when it's a very distal third fracture and it's a short oblique fracture, obviously the deforming forces are very high. So deltoid is pulling it up and your distal part goes for lateral angulation and varus. As Dr. Bopi said also told, it goes for lateral angulation and varus. We know, everyone knows the anatomy of the radial nerve. It goes from the radial groove and goes into the lateral. So that is the thing. When you try to do a close reduction, very well discussed by Hodge and Lewis. When you try to do a close reduction, the radial nerve, make guys and trap. Or you leave it like this, the callus, the absorbent callus can form. And the radial nerve, when the radial nerve has got a problem, then it's really difficult to go and explore the radial nerve and do a surgery. So that is regarding anatomical part.
Santosha, can I just interrupt you? Your voice is not very clear.
Not now. Can you hear me?
Yeah, much better now.
Okay, fine. Yeah. So what is the treatment? Yes, I agree. Hippocrates is the man who started the non-operative management. We have Hippocrates bench reduction tool, and this is what done in the ancient period. We do immobilize the patient and we put them there. But where we are in 22nd century, yeah, we have a now AVO. We know AVO principles should be followed when we are doing surgeries, and all the 4 principles should be followed. And we have beautiful implants, armamentorium, where we can do minimally invasive surgeries and we can get a good fracture stability and the patient can get back to work even within a week or 10 days after the fracture. So I will go to the literature evidence. So what is it? So this is a large cohort study. It's a retrospective cohort from Australia by Francis et al. They had 126 humerus fracture patients. The non-operative group had 96 patients and operative group had 30 patients. In that, non-operative group had 33% non-union. So it's a quite high compared to operative group. So the other study done by Iran, this is a randomized controlled trial between humeral shaft plate fixation versus non-operative management. They had 60 humerus fracture. What is the union time between operative and non-operative? Again, the union time was much earlier in operative group compared to non-operative group. They concluded that open reduction and internal fixation might be superior to non-operative management. So the another paper, this is from Philadelphia. Yeah, humeral fracture, shaft fractures. This is a review by Woodgrove. So they told that what dictates whether this fracture should be treated non-operatively or operatively, the fracture pattern, the fracture location, and the identifiable patient risk factors may predict the poor outcome with non-operative management. So I say the fracture pattern, distal third fractures more prone for angulation and malunion. So I prefer to do a non-operative management in this patient. So again, this is from Tennessee, USA. This Westrick et al. It's a humeral shaft fracture, results of operative and non-operative management. This is a retrospective study, but they had 296 humerus fractures, 69 brace, and 227 operative. They concluded that conservative treatment has higher rate of non-union, and operative group has lower incidence of iatrogenic nerve injury and more infection. Yeah, infection rate is higher with operative group, but the iatrogenic nerve injury is almost similar in both the groups. And again, a review article by Clement et al. From UK, Edinburgh. He has told to offer operative management to all patients may be over treatment, and not to offer this at all would undertreat the patient. Again, this is a systemic review from UK. Again, operative versus non-operative treatment of humeral shaft fractures. In this, the main measured outcome were non-union, malunion, delayed union, iatrogenic nerve injury, and infection. The results were non-operative management resulted in a significantly higher non-union rate. This is the same what Gopi sir also quoted, but operative management higher iatrogenic nerve injury compared to non-operative management. So I will say how to avoid iatrogenic nerve injury. This is another paper by Jenard et al. From Philadelphia. They had 213 adult patients. Non-union and malunion was common in non-operative group. And in this, the non-operative group had 9.7% of radial nerve palsy compared to 2.7% in operative group. Okay. Again, this is the only Cochrane database review is available. Same thing what Gopi Shankar sir told. There is no evidence available so far from randomized control trial. Hardly we have 3 or 4 randomized control trials to ascertain whether surgical intervention of humeral shaft fractures give a better or a worse outcome than no surgery. So continuing, this is another RCT. This is by Matsunanga et al. A minimally invasive osteosynthesis with a bridge plate versus a functional brace for humeral shaft fractures. So what they have told, in 110 patients, they look for measured the outcomes based on DASH, constant motility score, complications, pain, and radiographic results at 2 weeks, 1, 2, and 6 months, and 1 year. The results were DASH was superior to bridge plate at 6 months. Non-union and angular deformities was less with bridge plating, but they also have the similar rate of nerve injury compared to the non-operative group. Okay. And this is the largest RCT available right now from Finland. This is the FISH trial. They say it was published in JAMA 2020. Initially, they told they got the approval for the trial in 2017 and they published in 2020. They had 82 patients. 78 completed the trial. They followed them for 12 months. So DASH score was 8.9% in operative group compared to 12% in bracing group. And 11 patients developed non-union in bracing and 3 patients had radial nerve palsy in surgery group. Conclusion, substantial amount of treatment of non-operative should move to surgery. So this is another Hummer. It's a multi-center prospective observation study which is going on in Netherlands. They are planning to include 400 patients. It's not a RCT, but it's going to be an observation study. It will be given to the discretion of the surgeon who is going to treat, and maybe at the end of this result, we will come to know whether which is good, better or non-operative, because this trial is not a single center, it's a multi-center study all over the European countries. So I will come to a case example. Why? This is a 56 years old female with a short oblique fracture or a spiral fracture of the distal third fracture. We can see the varus angulation, varus and the lateral angulation of the humerus. So this can go for non-union. So we have, as I told, we can go by traditional approach where surgeons, most of the surgeons are trained by posterior approach. You can do a lag screw fixation, anatomical fixation. You can explore the nerve. There are a lot of posterior approach available. You don't want to go by classical posterior approach, which is described, which is a triceps, lateral triceps splitting approach. You can go by Mitchell-Grishay approach, where we go by a posterolateral approach. We identify the cutaneous branch of the radial nerve. You trace the radial nerve, you isolate the radial nerve, and you do your fracture fixation. So this is another example. Yeah, we do have complications, and you will end up in complications when doing a surgery. Yeah, this is another female patient. She is 60, female. When we went intra, the anatomical plate, initially the lag screw was applied, the fracture was reduced, and 2 lag screws was applied perpendicular to the plate. But the anatomical plate, the posterolateral plate, didn't accompany or contour this bone. Either if you push laterally, it's going more laterally away from the, if you push medially, it is going to the fossa, and the proximal part is going so medially. So at the end, we should contour 2 plates, and we did the surgery, and we had good success. Within 3 months, the fracture is united and the patient doesn't have any functional disability. So we are worried about open reduction, infection, radial nerve palsy. Yeah, it's a very good paper from my senior colleagues from the institute where I was trained. It's my mentor, Manase. He has written this paper. It's an anteromedial surgical approach. This is a very good paper. It's a minimally invasive approach. You make a small distal incision in the medially, just above the medial epicondyle, lateral to the biceps. You get the brachialis, and you can have the contouring of the plate medially and proximally also. It's between your pectoralis major and biceps. Biceps will retract all your vessels, and we have 3 holes. You can do a MIPO, minimally invasive surgeries. It's a very good success. That's what they published in techniques in shoulder and elbow surgery in 2020. So we can use a traditional MIPO, which is described in AVO. That's the anterolateral approach. You can make a small incision, but you can contour a normal plate also, normal narrow DCP. You contour it. You can have either a 2-hole or a 3-hole. 3 is enough. 3 screws is enough distally, and 3 screws is enough proximally, and you will have a good callus formation and healing. So why I want to do a surgery for this guy? Again, compliance of the patients is very, very important. And in non-operative group, our patients who wants to get out and go for work or whatever it is within a week or 10 days time, they want to use the upper limb. In those scenarios, it's operative management is much better than non-operative management. So in literature, it shows that 30 to 38% gas are non-union, and radial nerve palsy is equal both in non-operative and surgical management. And a good pre-op planning and choosing the correct approach will give favorable outcomes. You can avoid radial nerve injury and infection. Thank you.
Thank you, sir. It was a good presentation. The panel, the discussion is open. Any questions? It's a common topic. Please come out with the questions.
To Dr. Gopi Shankar, sir. In your series, you had showed that you had quite a good number of union in transverse fractures.
Yes, sir.
Actually, the literature is that the transverse fractures are more prone for distraction at the fracture site, and then the chances of non-union are quite delayed union are quite common in transverse fracture. But surprisingly, your series showed that quite a good number of healing in transverse fracture. That is my question number 1. And then your series had almost about 80 to 85% of healing rate. So then what happened to the remaining 15 to 20% of the studied people?
Yes, sir. Actually, contrary to the literature, transverse fracture united well in our study, and it was the spiral fracture which failed to unite. So almost 15% we had non-union, which is 13 patients actually. Out of 83, 13 patients went for non-union. And as I said, what we saw all the comorbidities and all the other factors, we found only smoking was very significant. Probably that was a significant. Out of 13, 9 patients had smoking. So probably we are attributing to it, maybe true or not, but out of which almost all the other 13 went for surgery. We had to do intervene at 6 weeks. As I told, at 6 weeks, we usually look for the mobility and this thing. There is no signs of healing, or if there is no signs of this thing, we actually had to move to operative treatment.
I think the humerus is one of the most forgiving fractures to treat conservatively, provided the rotation is taken care. And the important factor is for the non-union is the distraction at the fracture site. So did you correlate how these 15 to 20% of the population ended up for non-union apart from the smoking? Any other factors, significant factors that really contributed to the non-union?
Fracture gap as such you have not measured.
Is one of the important risk factors. I do agree, but apart from the smoking,
Fracture distraction we have not seen as such. The gap we have not measured as such.
okay.
Yes,
So my question to Dr. Gopishankar, sir.
yes, sir.
Sir, this is Venkat here, sir.
Yeah.
We had, you showed a case where there was a hypertrophic non-union, and I believe most non-unions in humerus fractures treated non-operatively end up with hypertrophic non-union. So they eventually need surgery, some form of a fixation. What is your take on radial nerve involvement after the amount of callus that has formed? What intraoperatively do you find the nerve is entrapped, or do you find easier dissection possible around the radial nerve? So I would like to know about your experience regarding that, sir.
Yeah, the particular case which I showed is a patient with a polytrauma with a head injury. So patient was in neurosurgery ICU for long, so patient could not be taken up. And when patient came, we found out that patient had an exorbitant callus and this thing. However, to our luck, patient's radial nerve was intact. However, as he was asked, radial nerve injury post all this callus is again not very rare. Frankly speaking, I have not operated on any case with the exuberant callus in such a situation.
Okay, sir.
Yeah.
Any more question? Can you hear me?
Yes, come on.
Sir, any more questions? Shall we pass on to the next topic?
Yeah.
Sir, the next topic of dilemma is a 34-year-old female with intra-articular calcaneal comminuted fracture. It can be treated by open reduction internal fixation, or it can be treated by a minimally invasive surgery. So two scenarios are there, and we have two good speakers, Professor R.T. Parthasarathy from Salem, who is going to talk on minimally invasive procedure for the intra-articular calcaneal fracture. Sir, I welcome Professor R.T. Parthasarathy, sir. Sir,
Yeah.
take your dais.
Yeah, thank you. Thank you for your giving me this opportunity. Yeah, I am going to share my screen. Yeah, it's visible.
No, sir, it's not sharing.
Now it's visible.
Yes, sir. Yes, sir. It has started sharing.
Yeah. Okay. Yeah, good evening to all. Yeah, my given scenario is minimally invasive calcaneal fracture, intra-articular calcaneal fracture fixation. Coming to your introduction, the calcaneal fractures around 70 to 70% are intra-articular, around 30% are extra-articular, 10% are bilateral, 10% associated. You all know the mechanism of injury is axial load by the talus undergone the lateral process forces the subtalar joint into eversion and act as a wedge and produces the primary and secondary fracture line. Yeah, it's a secondary fracture line. So The radiographs needed are lateral radiographs shows the loss of height and changes in the angle and Harris axial view, and we have to visualize the central portion of the posterior facet in the Harris axial view. Other views needed are broaden views for entire visualization of the entire articular surface. We have to achieve the maintain the crucial angle of vision between 120 to 145 and Bowler angle between 20 to 40 degree. So the importance of CT will shows the CT is mandatory in all articular fracture. CT will shows accurate displacement of the articular fragment. The SX low porosity divided classified into tongue type and joint depression type. In tongue type, the fracture exit posterior to the tia Achilles insertion. The joint depression type, the fracture exit in the anterior to the tia insertion. So Sanders classified into 4 types. Initially they divided into 3 fracture lines in lateral, central, and medial. According to that, the type 2 having 2-part fracture, type 3 having 3-part, and type 4 3 or more comminuted fragments. They're coming to the treatment options. The non-operative treatment and operative have having the percutaneous fixation and minimally invasive reduction and stabilization and extension lateral approach with plate fixation. The outcome of the role of surgery remains controversial. If operative treatment is chosen, anatomical reconstruction of the joint and overall shape is mandatory for get a good clinical outcome. Non-operative treatment safe but poor results. Surgery, but the surgery having associated risk include there is an infection rate of 3 to 6%, wound breakdown, and even that leads to lateral amputation. Coming to the non-operative treatment, it is indicated in non-displaced articular fracture and minimally displaced articular fractures. The complications of conservative treatment include subtalar arthritis and even lateral exostosis, peroneal ligaments peroneal tendon dislocation with short heel with wide heel. The ideal timing of surgery for the essential approach 10 to 14 days after the development of the wrinkle test positive. So we have to wait 10 to 40, but minimally invasive surgery we have to do early to get a good functional outcome. The available implants, these are okay. Oh, sorry. Oh, 1 minute. The screen is visible?
No, sir, not visible, sir.
Now?
No, sir, it's not visible.
1 minute. I think some problem on my screen.
So it's not sharing, sir.
Yeah, 1 minute. There is some problem in my screen. 1 minute. Screen visible ஆகல ஒரு நிமிஷம் பார்க்க. Vijay?
Yes, sir, please tell me, sir.
Yeah, something is problem in my.
Sir, கேக்குதா சார்?
Yeah, audible only. Again, I am going to the.
சார் ஒன்றும் பிரச்சனை இல்லை சார். சார் உங்க பிரசன்டேஷன் அங்க இருக்குல்ல சார் ஸ்கிரீன்ல? இல்ல ஸ்கிரீன்லயே வரலையா? Sir, are you online? Sorry, sir. Am I audible? Shall you ask Venkatraman sir to deliver his speech? So that in the meantime, sir will get ready with his presentation. Host.
Hello.
Sir, shall we pass on to next speaker, sir?
Can you hear me?
Yeah, I am hearing you, sir.
Okay. Was there any problem? I also got
Yes,
out.
sir. Yes, sir. There is a problem. You are again logging. I can hear you. We can pass on to the next topic by Venkatraman, sir. After his talk, we'll be back to Dr. Pondicherry, sir.
Who is there?
Dr. Venkatraman. Yeah, Dr. Venkatraman is there.
Okay, Venkatraman sir.
Yes, sir. I'm here, sir.
Yeah, yes, sir. Sorry, sir. We will start with your talk.
All right, sir.
Please. I welcome you, sir. Yes, sir. Please share, sir.
Thank you. Is it visible now, sir?
Yes, sir.
So good evening, one and all. I would like to thank the Chief Organizer, Dr. Vijay Raghavan, and the rest of the organizing committee for giving me this wonderful opportunity to talk about this topic. So I'm going to talk in favor of a conventional open reduction internal fixation for an intra-articular calcaneal fracture. The case scenario that has been given to me is a 34-year-old female with an intra-articular calcaneal fracture. This is the information that has been given. We do not know what Sanders classification she has and what is the fracture pattern. So let's move ahead with this scenario in mind. I will choose an extensor lateral approach for this intra-articular comminuted calcaneal fracture for a young patient. So why? The key word here is intra-articular. Why intra-articular fracture requires an open reduction internal fixation? Because the principles of fracture fixation are quite clear. With respect to intra-articular fractures, our aim is to achieve anatomical reduction, a rigid fixation, and an early mobilization. Only if all these three principles are achieved, we'll be able to achieve the most optimal outcome. So let me ask some of the people here, or let me rather share this thought with some of the people here, who will choose minimally invasive for this proximal tibia fracture, for this bimalleolar fracture, or for this distal femur fracture. All of these fractures are intra-articular fractures, displaced, but I believe very few of us can really choose minimally invasive with guts and go ahead with minimally invasive. Most of us would like to open, see the joint surface, reduce it under vision, and then go ahead with the rigid fixation. But it is even more complex in calcaneal fractures. About the examples I showed, they are at least quite a little straightforward when compared to a calcaneal fracture. Why is it more complex in calcaneal fracture? Because we have a lot of other goals in addition to restoring articular incongruity. That is articular incongruity that we have to restore. So this is an articular facet depression of the posterior facet. So there is a depression as well as a step off. We have to correct the heel varus. So this is a heel varus that is visible in the axial cuts. And we have to correct the lateral wall blowout also. So we have three important points to address in calcaneal fractures. And all of these has to be addressed by a minimally invasive approach. Is it possible? Not everyone is Mr. 360 here just to kick the ball out of the park, no matter what is the line and length of the delivery. Very few talented people can still do it, but not everyone. So why there is so much of fear of open reduction with calcaneal fractures? Because of two major complications. It's wound dehiscence and wound infection. Both are different. Why does wound dehiscence and wound infection happen? Because of improper planning and improper assessment. Look at these fractures, proximal tibia fractures, ankle fracture and foot injuries. We can clearly see.
some problem.
Can I go ahead, sir? Hello? Can I go ahead? Am I audible? Can I go ahead?
I think Venkat, you go ahead.
Okay.
Venkat, go ahead.
Yeah. So look at these fractures. These are proximal tibia fractures, tibia shaft fractures, ankle fractures, foot injuries with a lot of blisters, because most of these blisters are hemorrhagic also. None of us are going to operate immediately in these conditions. We're not going to put an incision through these. We're going to wait for them, right? Just a second. So when to operate, that is the key with respect to calcaneal fracture. So you have to wait for the wrinkle sign. So here is a patient with calcaneal fracture. You can see some lateral wall ecchymosis in the lateral aspect of the skin, and you can clearly see some wrinkling. So this is a sign to know that, yes, the skin is ready to take an incision and the wound complications are to be minimized when this particular sign is visible. There are a few more precautions that we can use whenever we are doing an external lateral approach. We have to handle the soft tissues gently. No retractors to be used. If at all any retraction is to be done, it has to be very minimal and it should be transient. It should not be a constant retractor-based retraction. No usage of tooth forceps. Try to use non-tooth forceps, or you can even use the backside of the forceps to gently elevate the flap. And talking about flap elevation, make sure the incision is bone deep and the flap has to be elevated by subperiosteal dissection. Another most important point is we have to study the fracture in depth, understand the pattern of the injury, plan your steps in advance, understand the sequence of fixation, and execute it perfectly to finish on time. Any unnecessary delay in the surgery is going to increase your chance of wound infection, increase soft tissue edema, and thus contribute to more wound adhesions. So with the advent of low profile plates are no longer a problem with the lateral extensor lateral approach. You have very good thin plates, locking plates, calcaneal plates available that anatomically contour to the calcaneal shape. They provide excellent fixation, excellent rigidity, and you can mobilize. You have to understand the difference. Mobilization is very different from weight bearing. Weight bearing is still not allowed regardless of the approach or regardless of the fixation. But mobilization with a good locking calcaneal plate can be allowed. No need to put the patient on a POP. And finally, the wound has to be closed by Algover Donati suture. So let me just briefly touch upon this. Algover Donati suturing is a type of your mattress suturing, but you have to understand that the thread does not come out through the skin in the dissected flap. It comes out through the flap that is intact. So just look at this wound. So here we have an Algover Donati closure. The threads are on the flap that is intact, not on the flap that has been raised. The knots are placed in such a way that the knots are not on the flap that has been raised. So what is the relevance of this? It has been very clearly studied by even a randomized control trial that using this particular technique of wound closure, in fact, has a good incision perfusion when compared to a routine vertical mattress suturing. So it is thoroughly recommended for any foot and ankle injuries, all the more relevant for calcaneal fractures. Even if the closure is poor, the wounds do settle down. So look at this fracture. It has been poorly closed. The closure is tight. It's looking, no Algover Donati suture has been applied. The incision is insufficient. It is small, but still the wound at 6 weeks looks like this. But at 3 months, it looks like this. And at 6 months, it has healed. It does settle down, provided there is no infection. So the wounds do settle down. But what doesn't settle down? Malreductions. Malreductions don't. Here is a patient who was initially fixed with KYS, minimally invasive approach. So patient turned up 6 to 8 months later with a severe valgus malunion. You can see there are too many toe signs. There is valgus malunion, there is broadening of heel, there is shortening of heel. On the right side, it is on the right-hand side, right side calcaneum, you can see the malunion. It is not as appreciable as the left side picture, but you can still observe the too many toe sign here. There is a valgus angulation, there is a broadening of heel. These malreductions don't give a good outcome. You might have done a wonderful soft tissue outcome. The skin is healed wonderfully, but patient will not be satisfied. Patient will complain of pain and eventually will undergo fusion. Another important key point that has to be mentioned, any minimally invasive surgery, if we are doing and if we are not able to achieve the desired outcome, you can always convert to open. But in calcaneal fractures, MIS, there is no way you can convert this incision, the sinus tarsi approach, into an extensor lateral approach. If you fail to achieve adequate reduction with the sinus tarsi approach, you're done for. You just have to accept that reduction, accept whatever has come, fix it with whatever available implants that you have, and come out and hope to God that the patient has a reasonably good outcome. You can't make this incision, it will definitely lead to a collapse of the flap. It is going to end up with a catastrophic complication. So if you cannot do a perfect reduction, which is the prerogative for intra-articular calcaneal fractures, you can't do a minimally invasive approach. You have to go ahead with an open approach. There is no escape. You're stuck. So when should we use minimally invasive? You see this knife? This is a chef's knife. It's made by a company called Takashi. It's made in Japan. It's one of the most expensive chef knives. It's being used by selected chefs. It's extremely sharp. It can even cut through a slice of paper. If it is held in the air, it is very sharp. It can cut vegetables. It can cut your onions. It can cut your tomatoes. So does this Prestige knife. But which is cheaper? The Prestige is cheaper. Which is safer also. We don't have a risk of injury. The Prestige doesn't have a risk of injury. So most of us are going to use the knife on the right hand side and not on the left hand side. Likewise, MIS is not for everyone. It is not for every fracture pattern. Very selected fracture patterns and very experienced surgeons can get away with MIS, not all of us. So I would like to conclude my talk by saying this. First, do no harm. So if you are sure that you are experienced enough with MIS and the fracture pattern allows you to do an MIS, go ahead with an MIS. Otherwise, extensor lateral approach is the workhorse for intra-articular calcaneal fracture fixation. Don't try to do a fancy MIS approach and give a suboptimal outcome. That is harm to a patient. So I thank once again everyone for this nice opportunity. I would like to conclude my speech. Thank you.
Thank you, sir. It was a nice speech. Then we will call upon our Professor Parthasari, sir, to talk on the minimally invasive calcaneal fixation.
Oh, sorry for the interruption in the presentation. Now it's visible?
Yes, sir.
Okay, okay. Yeah. My talk is minimally invasive fixation for calcaneal fractures. The introduction, around 70 to 75% are extra-articular fracture. Yeah, audible?
Yes, sir.
Okay, okay. So mechanism of injury. Yeah, our aim is to regain the angle of design between the 120 to 145 and Boller's angle between the 20 to 40. The CT is mandatory in all articular fractures. The CT definitely clearly shows the displacement of the articular fragment. We have to identify the fragments, the lateral wall, anterior process, and lateral articular fragment, and tuberosity fragment, and also medial sustenance fragments. So SX laparosity classified into tongue type and joint depression. Sanders classified into type 2-part fracture, 3-part, and comminuted fracture. The options are non-operative and operative. The non-operative treatment having the complications like subtalar arthritis, lateral exostosis, peroneal tendon dislocation, and short and with wide heel. And the ideal timing of surgery is after the 2 weeks for the extensional approach, but minimally invasive approach is possible to, it is ideal to do the surgery before 8 to 10 days. The history of minimally invasive surgery first started by Estes in 1934, then Gisain popularized in the US, then SX laparosity found it is useful in tongue type fractures, and Tornato modified by using the replacing the pins with screws. The types of minimally invasive surgeries are the percutaneous reduction of the fragments by Kirschner wire or Steinman pin, and distraction by using the medial and lateral external fixators, and ligamentotaxis with subsequent percutaneous screw fixation and using the sinus tarsi approach. What is the prerequisites for minimally invasive surgery is ideally done before 8 to 10 days of the injury, because after that the fracture is going to consolidate, then fracture margins become sticky and not easy to manipulate. So the results are poor if minimally invasive surgery is done after 10 days. The indications are the patient-related factors like systemically critical conditions and polytraumatized patient, contraindication to ORI, and soft tissue related with poor soft tissue with compartment syndrome. And the fracture patterns are the tongue type fractures and all extra-articular fractures, and also nowadays is possible to all type 2 Sanders fractures. The principles relies on the principle of ligamatotaxics. The entire joint capsule along with the ligaments surrounding the calcaneum, talocalcaneal, tibiocalcaneal, and fibulocalcaneal ligaments are aid the reduction. Our aim of fracture fixation are restore the height and length of the calcaneum and correction of valgus alignment of the tuberosity and correction of heel widening and repositioning of the lateral wall with posterior facetal anatomical or near anatomical reduction. So the various approaches are available for sinus tarsi approach, minimally invasive posterior, that is pararectal approach for extremely weak fractures, and minimally invasive lateral approach. This incision is done just below the sinus tarsi approach. Coming to the sinus tarsi approach, thin and peroneal retinaculum incised from the tip of the lateral malleolus to the base of the fourth metatarsal subtalar joints are visualized, and articular depression is elevated by using the osteotome or a small periosteal elevator and stabilized with the wires or screws. And the techniques for tongue type fractures, the Essex low porosity tongue type fractures and Sanders type 2, see here either 2 Steeman pins parallel to the either side of the tendocles or 2 K wires in the tongue fragment. Then use the tornado reduction, or the Essex low porosity reduction, disimpaction, and elevate the posterior tongue fragment. Same time, the heel widening if present, you have to give the medial compress the mediolateral displacement by using the ball tip clamps. Once the reduction is achieved, apply the multiple K wires from posterior to the anterior, both sides of the tendocles. In the plantar aspect, we support the posterior facet. If there is a calcaneal cuboid joint involvement, there is comminution, you have to advance the K wire to the cuboid. Even there is unstable, give the more stability, advance the wire into the talus. Coming to the joint depression type, the K wire from the calcaneal tube, apply the first K wire from the calcaneal tuberosity. The wire must be from posterolateral to anteromedial to correct the varus angulation. This is common in joint depression type. Then do the sinus tarsi approach, identify the lateral articular fragment, elevate, reduce, and stabilize with wire or screws. If there is a widened calcaneal body, compressed by the use of the clamp or using the milking maneuver. Then apply the wires from postero inferior to the talus, cross the subtalar joint, even calcaneal cuboid joint. Another 2 K wires parallel to the body of the calcaneum beneath the facet that will support the subarticular posterior articular facet. Even the wires may be replaced with cannulated screws. Once screws is applied, if you apply the compression screw through the sinus tarsi approach from lateral to medial for supporting the apply the screw from lateral articular fragment to the medial sustentaculum tali. For supporting the posterior articular facet, the wrap screw, the cannulated fully threaded screws apply the subchondral to the posterior facetal fragment. So throughout the surgery, maintain the physiological valgus because tendency for the hind foot to fall into the varus as the patient in the lateral position. So examples, the closed extra-articular tongue type stabilized with the 1 screw. The another case, the tongue type fracture, stabilize the angle of design is widened, stabilized with 2 screws. The another case, the joint depression type fracture, the minimally invasive fracture fixation by plating, so CT, the sinus tarsi approach, the posterior articular facet is elevated and stabilized with initially temporarily stabilized with wire, then applied stabilized with recon plate. It's a 2 months follow-up, but the patient having the residual varus deformity. The another case, the preoperative X-ray is a broadened view. The type 2 Sanders 2A, so stabilized with articular fragment is elevated and stabilized with percutaneous screws. So post-op and follow-up clinical picture. The another case, the preoperative X-ray and CT. This is stabilized during the sinus tarsi approach. The lateral articular fragment is elevated by using the osteotome and stabilized with temporary K-wire. Heel varus is corrected by using the Steinman pin, and this is the final fixation. So after K-wire removal, this is a functional outcome. So another case, the close reduction with percutaneous pinning was done. The articular facet is elevated by the joystick method, and further the stabilized with multiple K-wires. So another bilateral calcaneal fracture. So CT is a broadens view of both the right and left side. So initially stabilized with both the sides are stabilized with percutaneous screws. So immediate post-op. So 3 months follow-up. The left side 3 months follow-up. It's a follow-up after the 7 months. So coming to the literature, this literature shows the largest benefit of sinus tarsi minimally invasive approach was found to be significant reduction in wound complication and operative time, where the time to closure may have accounted for the latter difference. The another study shows the percutaneously reducing fixing a calcaneal fracture minimize the complication and achieves and maintains the extraarticular reduction as the standard extensional open reduction and internal fixation. But intraarticular fracture extension lateral approach provides better reduction and fixation. Another systematic review of literature shows the traditional external lateral approach provides better exposure of the anatomy of fracture, yet carries significant higher risk of wound related complication, but minimally invasive reduction and percutaneous fixation effective and comparable clinical, functional and radiological results with lower incidence of wound related complication. Another study shows the results were best in ORIF but having the high risk of complication, but the reduction and stability is lesser inferior in percutaneous surgical approach. The another study shows the benefit of sinus tarsi approach is significant reduction in wound complication and operative time. So coming to the algorithm for the extraarticular fractures, the tongue type and tuberosity calcaneal beak fracture better for the percutaneous reduction and fixation. In intraarticular fracture, all the tongue type fractures and fracture dislocation better stabilized with percutaneous approach. So take home message, treatment depends on the severity of the injury. Articular reconstruction and reduction of the calcaneal body seem to give the good functional outcome. The mini open or percutaneous surgical techniques seem to be lower risk, having the very little complication rate and maintain the benefits of surgery. Thank you. Thank you for your patient listening.
Sure, very good presentation, sir, on percutaneous minimally invasive fixation of intraarticular calcaneal fracture. The panel discussion is open for discussion.
Sir, Patsari, sir.
Yeah. Tell me.
Sir, in minimally invasive approach, when you attempted, how many times you accepted a mal reduction and came out with this sinus tarsi approach?
Thorough preoperative planning is essential.
Yeah.
But already what Venkatram is already told, once we open sinus tarsi approach, we have to reduce, we have to get maximum near anatomical reduction. We are not able to convert. Then once you open the sinus tarsi approach, we are not able to convert it to. But you tried in percutaneous approach, then it is possible to convert it to extensile lateral approach. We are converting in more than 2 or 3 times. We try to not initially applying the sinus tarsi. We try to do in the percutaneous reduction. That is easy, but always keep all the implants ready for converting into extensile approach.
So the rate of subtalar arthritis in minimally invasive, even though we think it's an accurate reduction, the chances of arthritis is always there.
Yeah,
the percentage
definitely.
of Yeah, the percentage of arthritis in your experience in minimally invasive.
In our experience, we encountered 2 or 3 cases having we converted to the primary secondary fusion. But the literature shows the conversion, the latter fusion rates between the sinus tarsi and extensile are same, around 9 to 11%.
Okay. So one more question for Dr. Venkatraman sir.
Yes, sir.
I did one open technique,
Yes, sir.
extensive lateral approach,
Yes, sir.
and for the retractors, I put the Steeman pin. That means what? The 2 mm KOS.
Yeah.
One in the talus and
Yeah.
one in the cuboid for the retraction.
Yes,
Whether
sir.
it is correct or not.
Yeah, that is correct, sir. That is how you have to use for an extensor lateral approach. And make sure you place a wet gauze over the flap that has been elevated and retracted so that it doesn't undergo desiccation and constant exposure to the air. So that is the ideal way to retract, rather than putting a lever or putting a retractor or holding it with a Alice forceps. That's wrong. So this flap has to be gently handled and minimally touched once it has been elevated. Putting K-wires through the talus or through the lateral malleolus or through the cuboid is the ideal way to keep the flap away from the field of surgery.
Vijay, yeah.
Sir, please tell me, sir.
Yeah, Vijay, use 3 KYS. That is called no touch technique. One is in the cuboid, another one is in the neck of the talus. Finally, you apply 1 K wire in the
Cuboid.
fibula.
Oh, sorry, fibula. Sir, I learned this from you only, sir. From your presentation only, I learned this. What happened? There was a skin necrosis only in the K-wire side of the flap. It took a long time to heal.
So use the gauze, wet cloth.
Wet gauze.
Already Venkatram told. Then you use the wire, wet gauze between the flap and
Between the wires. Between the wires
Yeah.
and the
That is
Yes, sir. Yes, sir. I did it. The thing is that we had an axial view of the X-ray. The reduction was good. We did grafting also, bone grafting also, and we did a minimal plate. Means what? Thin profile plate.
thin profile.
So
plate, yeah.
thin profile plate. We put screws, everything. The X-ray
Okay.
was good. X-ray was so good, but we could see from his footwear the lateral aspect of the medial aspect of the footwear is warning out early than the lateral aspect of the footwear. He showed his footwear. The medial aspect of the footwear.
That means the patient having any valgus deformity.
Yes, yes. So it
No,
it's
sir,
a-
but the axial view of the X-ray was good. Is good.
So you probably have to get a heel alignment view, sir. Maybe there is a valgus. From what you are describing, there is possibly a residual valgus.
Valgus
There might be an overcorrection of your heel varus, so which is explaining the medial wear and tear of your footwear.
Yeah, I wanted to share that X-ray so that we have a nice discussion like that.
Oh, sir, if you have it, you can share it, sir.
Yeah. Now I don't have, sir. Tomorrow morning I will share to the speakers. We'll have a
Okay.
discussion.
Better peroperatively, you always take a broadened view. That
Yeah.
is the
Yes, sir.
ideal view that shows the articular reduction.
Articular reduction.
Sir, your position of the patient for a minimally invasive, your position of the patient.
Now, both the minimally invasive or extensive approach, I use floppy lateral position. Then only you are able to take all the 3 views: lateral view, Harris axial view, and broadened views.
Yes,
So
sir.
always use the floppy lateral position. That is ideal to take all the 3 views peroperatively.
Sir, Venkatraman, sir, your view?
Yeah,
Your
same here.
perception?
Floppy lateral is
Yeah,
ideal because, as sir said, it is easier. I have personally used lateral position for unilateral calcaneal fractures and a prone position if there is a bilateral calcaneal fracture. And I have not encountered much of difficulty. But sir is right. I think a floppy lateral is going to make some broadens view and all that view much easier than a straightforward lateral view, a lateral position.
Prone is a tougher thing, no? Prone position for the.
So in bilateral calcaneal fractures, prone is actually recommended. I think I'll ask sir's experience also, Partha sir's experience.
I use 2 or 3 bilateral cases, but we do after 2 days of one side fixation, but I always use the floppy lateral position.
Okay, sir. Okay.
Yes, sir.
Staged procedure only.
Stage procedure. Okay.
It's a nice message, sir.
Okay.
Sir, any more discussion, sir? Shall we wind up?
Yeah. Any other question in chat box?
So there was one question where some Dr. Udaya had asked, what is the take on conservative management of calcaneal fractures? Because some studies show there is no difference between conservative versus surgical management with respect to AFR scores.
I already explained in my talk. The
Yeah.
conservative management is indicated only in undisplaced intra-articular
minimally
fractures,
displaced fractures.
minimally displaced. Yeah. Otherwise, it lands up in a too much of complications. If the severe articular depression, there is a complication.
Absolutely, sir. I think there was a previous school of thought because of the fear of wound complications with respect to calcaneal fracture fixation that better to non-operatively manage, and if a complication comes, we can manage at a later date. The complications can be managed at a later date. But with the advent of minimally invasive technique and with the advent of much better implants, now we are sure with with the operative management for intra-articular fractures, there is no question about their efficacy.
Yeah.
Thank you, sir. It was a nice discussion.
Thank you.
Thank you, sir. Thank you, sir. We are at the end of the session, giving a vote of thanks. Saravanan sir is there? Saravanan sir from Korekal. Saravanan sir. So, okay, sir. Then I'll be in a position to give the vote of thanks. I sincerely thank Professor Rajagopal, the scientific chairman of POA, to give this topic. Selection of topics is a very interesting topic, and I sincerely thank our speakers who have put much effort. A simple topic, but depth on it. So really, they have done the homework. On their presentations is clearly seen, and given a message to the youngsters. And I'm still learning from their presentation. Thank you, sir. Thank you, presenters. And finally, thank our OASIS secretary, Dr. Anin sir, who have been always helpful to us, and you are supportive to bring out this webinar. And last but not the least, our delegates who actively participated in this webinar. Thank you. Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, Vijay.
Dr. Vijayaraghavan, sir. Hello.
Hello.
Yeah, so should I close the session for today?
Yeah. Please, madam. Please, madam.
Okay, sir. Thank you so much.
Thank you.